Hello, everyone, and welcome. My name is Corey Thornton. I am the managing editor for market intelligence at Open Minds and will serve today as the moderator. Today, as part of our weekly executive web forum series exclusively for elite members at Open Minds, Senior Associate Paul Duck will walk you through getting paid more for what you do, and we'll discuss practical ways of approaching payers with the goal of increasing rates. Mr. Duck brings over 40 years of experience in leadership and management, focusing on managed care, health information technology organizations, strategy, business development, and market expansion. Before we get started, we have a couple of housekeeping reminders. Your audio will be muted through today's briefing, but we welcome your questions and comments via the question box on the right-hand side of your screen. You can send your questions through the briefing, and afterwards we will field those questions. The slides and recording from today's briefing will be available on the Open Minds website starting tomorrow. And with that, Mr. Paul Duck.
Thanks, Corey. Appreciate it very much. Good afternoon. Thanks for joining us today. So this is a webinar that really, I think, focuses on an area that everyone's interested in: how to get paid more for what you do. And in putting this together and really trying to understand it, I think that there are really a plethora of ways if you action them, and we're going to discuss those today. So let's go through the agenda for today's webinar. Next slide, please. So first one is we're going to go where were we before this pandemic, and then we'll talk about what's changed, what are some of the impacts. Then we're going to talk about really the collaboration methods and ideas for working with payers and how do you get them to pay you more. And then we'll get into the tactics. The part that I really like to talk about is, how do you make this happen? How do you action it? How do you, actually see the increased revenue? What are some of the things you should be doing or considering in your organization? And then really getting into some to-dos, and really kind of trying to wrap it up with some things that are very actionable from the standpoint of walking away from this, you'll be able to go and actually do some things that should yield, getting paid more for what you do. So let's go ahead and jump right on in. So where were we before this pandemic, and what's changed? So I love this metaphor. So go ahead, Nina. Next slide. There we go. So pre-pandemic, I think it's safe to say, when thinking about providers and payers, I think about cats and dogs. So two facts that we know: cats don't like dogs, or by the way, trust dogs, and dogs don't like or trust cats, right? So I think that's a good metaphor for providers and payers, kind of pre-pandemic, if you will. So I love some of the statements that I hear, and I kind of put some quotes out here. And these may sound funny, but I promise you, these are real executives that have said these things. So believe it or not, you make us jump through unnecessary hoops for no good reason. Or I know more about you than you know about yourself, and what I know isn't pretty. Then there is, I could easily do a better job than you. And then there's of course, you're lucky we allow you in our network. And you're lucky to have us in your network. And we're the very best at what we do. Why don't you get it? And then finally, your cost of care is outrageous and your outcomes are no better, or they're potentially even worse than everyone else. So again, very conflictual cat versus dog kind of relationship. Dog doesn't like cat, cat doesn't like dog, dog doesn't trust cat, cat doesn't trust dog. So let's move on. So that's kind of sets the stage here. So the new era in what we can expect now, both from the standpoint of in the pandemic, but also going forward beyond the pandemic, providers need payers, and guess what? Payers need providers. And that's really kind of creates the perfect partnership where there is inherent need. We've also seen, by the way, payers become providers and providers become payers. So from that standpoint, you see almost a morphine in the process as well. We'll talk about that a little bit later. In a value-based payment shift, payers and providers, their success are tied completely together. So therefore, there's really, this need for transparency. There's no longer, I'm not going to tell you what I'm doing because of a lack of trust. There has to be transparency. And obviously, for there to be risk sharing, that's incredibly important in terms of really being able to help drive a relationship that's that there is one partner helping the other. And I think, the other one is that both the payer and the provider, but especially the provider organization, must become significantly more data driven. Let's face it, payers probably have, just through your claims data alone, what they know about provider organizations is pretty stunning. So from that standpoint, having the provider organization become much more data driven, and we'll take you through a model I think that really works and really talks and speaks directly to what data driven means a little bit later. And then, the success for providers will really tie their ability to becoming some part of an integrated delivery system, an ACO, a provider-led entity on a local basis. We know healthcare is local, and certainly that's not changed in the pandemic. But I think one distinction I think that's incredibly important and I think really helpful in terms of helping providers understand payers a little bit better and having payers understand providers a little bit better is that the provider's role in a partnership or in a shared risk arrangement with a payer is performance risk. Providers know what you do, you know who you treat, you know what kind of outcomes there are expected. So performing on those objectives is really, really something that the provider organization knows incredibly well. The payer's role is insurance risk or financial risk. They're the ones putting up large sums of money for, bonds if they're required, or taking on large financial risk or insurance risk. So the financial risk, it's the reason why you see payers with team of actuaries. They want to understand this from a hardcore data standpoint and being able to really kind of solve, what that looks like. And I think providers need to start to become more like the payers in that regard, and vice versa. The payers need to become more like providers in understanding the elements of performance risk. But it's really that distinction I think is really important in terms of really kind of helping that relationship become much more cohesive and dependent upon one another in this new era. Let's continue. So the hidden drivers. So if you look at what the pre-pandemic, the reality is that a lot of the things that were going on from a health indication standpoint are actually likely to get much worse. So, what do we spend on being healthy? 88% is spent on medical services, 4% on healthy behavior, and 8% on other. And I think this is the important one. While 5% of patients account for 50% of the whole of all of healthcare expenses, but with behavioral disorders being one of the key drivers, 68% of adults with behavioral conditions also have medical conditions. So we're going to talk a little bit more about that because I think it's important to realize, and as the old saying goes, is follow the money in terms of where if you're going to really try to solve a problem, you have to understand where the problem is and what are the areas of opportunity. So let's continue. Here, if you look at just social determinants of health and the leading health indicators, you look at the uninsured population, and this is a graph between 2008 and 2017. You see certainly, a sharp decline here in terms of the uninsured population, which means people are able to take care of their health insurance a little bit better in terms of, as the time went on. But also on the right side of the screen, you see what the U.S. healthcare coverage looks like, and you can see those percentages drastically increasing between 2009 and 2019. So again, a lot more money flowing to the system, a lot more around, being focused around the spend within that environment. So let's continue. And if you look at the factors that influence health status, and if you look at the positive side of this, is that 51% is lifestyle. So that's some stuff that we can control: smoking, obesity, stress, nutrition, et cetera. So all of those things are things that we have the ability of control. And a lot of those things too is behavioral health actually has a huge impact in terms of being able to really kind of weigh in terms of helping individuals with these types of lifestyle choices and situations. 10% on healthcare, 19% on environment, and then 20% on human biology. But again, looking at the factors that 51% really can fall into that idea around controllable expense. And that's where, unfortunately, I think we've actually gotten worse as a country in an area where we have to make drastic improvements. And you see a lot of, certainly insurers now wanting to provide incentives for people to have healthy lifestyle and providing benefits around those. Let's continue. Now, following exactly what some of the major commercial payers are doing here. Here's some examples. Just, I mean, there are many of them, but United Healthcare invested $350 million in housing programs over 6 years. Blue Cross and Blue Shield Association partnered with Lyft. Aetna and NQF partnered to promote payments to organizations, that were focused on social determinants of health. And in 2017, Kaiser announced their plan to invest $200 million to help address housing instability, which again, we know is a huge driver in terms of healthcare cost. Next. A few more. CVS Aetna merger greatly expanded access to their Minute clinics. And in Medicaid, plans mainly operating under 1115 waivers, really are now looking at paying for those non-healthcare services that relate to social determinants of health, like transportation, short-term housing, food, et cetera. And then Medicaid plans are increasingly requiring screenings for social determinants of health, because we know that that has a significant impact. So again, we have the ability of actually correcting the course here through some focused initiatives, and certainly the commercial payers get it. And it's an area I think that as provider organizations, you also need to be figuring out ways that you can intervene if you haven't, in terms of social determinants of health, because again, that's where some of the impact financially can be. Next. So if you look at in the era of COVID-19, again, we've seen obviously a lot of things happen. Certainly, the whole pandemic was unexpected, to say the very least. But if you look at these graphs, again, respondents reported feeling anxious or depressed within the past week. You can see, both people, all respondents, but also those that experienced job reduction or loss. And you can see it's pretty substantial. Also, looking at the reported level of distress related to COVID-19 in general, again, looking at high distress, moderate, and minimal, both all respondents as well as those with job reduction or loss. But probably the big concern one, and it's been written quite a bit about, and probably many of you have read articles about this, is the respondents, the level of reported substance abuse. 1 out of 4 reported binge drinking at least once in the past week. 1 out of 5 reported taking prescription medicine or drugs for non-medical reasons, and 1 out of 7 reported using illicit drugs. So big problem of addictions getting worse. And again, the stress level of the pandemic itself has actually created even a larger mental health crisis in this country and worldwide, frankly. Okay, let's continue. So again, real quickly, and probably many of you have seen this before, but COVID's kind of amplified a huge problem. So if you look at those individuals with a behavioral health diagnosis, it makes up 23% essentially of all people who are in the healthcare system, if you will. And if you look at non-consumer healthcare spending in terms of billions of dollars, you look at 7% is spent on behavioral health services and 53% is spent on medical services with those that have a behavioral health condition. So if you add that up, it's 60%, but it comes in at $1.23 trillion. And that is a gigantic number. So again, these numbers were pre-COVID. So the COVID-19 pandemic has actually stressed an already existing problem. Probably you'll see these numbers increasing substantially, which are already daunting in terms when you think about in terms of what we're spending to address some of these issues. So let's continue. So the second thing I want to talk about is the collaboration. So first thing you have to do is really understand from a provider's perspective, what are the payers' pain points? I mean, what is it that they care about? So I kind of drew up kind of my top picks here. So let's look at the first one. Access. So everybody knows access to care, and having quick, reliable access to care can really have a profound impact in terms of people's ability to both seek treatment and also stay in treatment. But access to care is obviously, from a payer playbook standpoint, is absolutely number one. Number two just happens to be access. And number three, it's access. You getting the point here? Number four, ER diversion and admission prevention. Huge. I mean, again, these are easy to kind of diagnose and fix in some cases. I mean, I'm not saying that providing access is easy to fix in general, but we see some capabilities being developed that will allow us to maybe kind of start to drive some success around telehealth and other types of modalities. But ER diversion and admission prevention is top of mind for hospitals. I mean, they do not want people with severe mental illness, for example, to be in their emergency room and they are seen, being readmitted into their services. They're being, kind of financially punished, if you will, by commercial insurers, for having a readmission problem, and also that seeing those. But this is something that providers can do. You can actually, and there are some great examples out there of organizations that have put ER diversion programs in place and worked with general hospitals, on a local basis, and been able to actually get people into the right kind of services at the appropriate time and really start to deal with the problems that they have. Number 5. Readmission prevention, real important. So, after somebody leaves a psychiatric hospital or hospital setting with a behavioral health issue or addictions, preventing them from being readmitted is, again, a huge, huge issue, and it's a pain point for payers. So pay attention to these. All of these, if you had a program that addressed this, I promise you could get the attention of payers. There's no payer that doesn't care more about these few things, frankly, than practically anything else. Let's continue. 5-day follow-up after psychiatric hospitalization, one of the HEDIS measures. Really important that follow-up happen. And why is that? The reason why is because we know that if that follow-up does happen and somebody is actually seen within that 5-day time frame, it actually has a significant impact in terms of readmission prevention. And we know that the likelihood of success with outcomes it significantly improves as well. So it's important that we actually, see a lot of measurement around the follow-up after psychiatric hospitalization, which is, again, the most intense part of treatment in the treatment spectrum, if you will. Next. 30-day follow-up, the other HEDIS measure. So again, if you look at the 5-day follow-up, but also you have the 30-day follow-up after psychiatric hospitalization, these are really important measures in terms of if they're done, and if both are done, there's a significant impact. Those of you who've seen some of the NCQA data that really have talked about when these are actually operationalized, what's happened in terms of improved outcomes. Very, very significant impact. All of these are things that provider organizations need to be paying attention to because these are significant pain points to payers. Continue. So how to provide telehealth and other virtual services to their members. I mean, that's what payers are obviously caring about now, and obviously in the pandemic world now, being able to deliver those telehealth services becomes really important. Obviously, if you just look at it from a simplistic standpoint, I mean, if you're in a rural setting, there may not be the types of providers that are necessary for the type of treatment that's required. That telehealth can, in some cases, actually replace the need for somebody to be physically present. It's not a one size fits all kind of a solution, but telehealth, we've seen organizations do massive expansion of their telehealth platforms and services since the pandemic, and that's an area where you have to be engaged at one level or another. It literally is starting to look like many of the outpatient services that have been bricks and mortar are being replaced with telehealth services. And while we don't know what the post-pandemic era will look like, I can virtually assure you, based upon feedback that we've heard at Open Minds from both provider organizations, but also from payers and consumers, all of them cannot see us going back to an era where telehealth is just a small volume service that's added on. I think you'll see a significant increase, and you see a lot of investment happening in that area. Next. Possible new areas, PPE expense and usage against, infection rates, virtual engagement percentages, all of those really will play a role, that you have to kind of take into account now that we're in this pandemic era where you have to acknowledge, in your cost factoring, you have PPE expense now where before you probably did not have that level of expense, but it's something that now has to be considered, and you have to figure out how you're going to pay for it as well. Let's continue. So the post-pandemic implications are really important to note. So I think these are the big ones. These are the cornerstones, if you will, in looking down the road. fewer larger behavioral health provider organizations. I think you're going to see a reduction in the size of massive organizations, if you will. Many behavioral health professionals will continue to work virtually, and again through that telehealth model and in other ways. And outreach and access issues will be addressed through that virtual kind of modality, if you will. The payers' budgets are being reduced as a result of this pandemic as well. So again, we don't see a quick recovery by the budgets the payers will have to be able to even fund services. So the reality is that we have to acknowledge that payers are also operating with fewer dollars. And then the care at home movement. We see much more in this movement probably over the last 15 years, where more and more of services across all of healthcare are moving much more towards an ambulatory environment. But we now see, both in senior services, but also in other types of, addiction treatment now happening in the home. I mean, there are lots of models now that are being proven out to be highly, highly effective, where the in-home model does work, and it works phenomenally well and at a much, much lower cost point, frankly. The payers know this. So again, these are implications that you have to pay attention to. Continue. So let's first talk about the first bullet there, the fewer larger behavioral health provider organizations. So, I kind of broke this into implications. So what are the things that are happening? And then on the other side, what are the actions that you really need to be thinking about, strategizing about, kind of developing a plan around? So the implications around fewer larger behavioral health provider organizations, again, I think it's an opportunity for organizations to be much more diverse. You have a chance to actually move into other service lines potentially. We'll talk a little bit more about that in a minute. More non-traditional players as competitors. I mean, again, as you have fewer larger behavioral health organizations, you also have some smaller organizations that are able to come in with a lot of innovative models. I mean, and technology is playing a role in that. Payers have more dependence on smaller organizations. A real big one is that, payers once upon a time were highly reliant on the gigantic behavioral health organizations. We're now, to build out a strong, stable network where good work is being done, they're having to look at those smaller organizations, and they're becoming much more dependent upon them in terms of their service delivery and the way they allocate their network. But the actions you should be taking as a result of this, mergers. Like other organizations, I think it's a, looking at other behavioral health organizations that may be a lot like you, that have the same culture, that may have, a significant presence in a place where you could, together work much more efficiently or effectively. It's something I think a lot of organizations are looking at. Mergers with complementary service lines. You might be merging, something where it's a service line that you don't necessarily have the capital to stand up. So maybe there's a merger that's a natural partnership, where, if you're an IDD provider, it's, some kind of school-based service or an in-homes type of service. If you're a behavioral health provider, it could be something like, using primary care for severely mentally ill. There's a lot of things that you can do in terms of trying to put organizations together. But again, I think at the end of the day, the most important thing here is we're in an era where you have to be innovating. You have to be innovating continuously. And I think that's important for you to realize, is that innovation is really key. And when I talk about innovation, I'm talking about service delivery, I'm talking about technology, I'm talking about thinking differently than you have perhaps in the past. And a lot of times we have a natural tendency to say, well, that just won't work. Telehealth won't work. I mean, there's no way that it could really replace a face-to-face, which is probably true in some types of treatment environments, but there are other types of treatment environments where it's a tremendous benefit. So the reality is that we have to stay open-minded and really being able to look at the natural partnerships that could be forged out of any of these innovations as well. We have to develop a plan to negotiate with payers as well. I can't tell you how many organizations that we work with literally that have not negotiated rates with payers for years. And believe me, we'll talk about this in a minute. We'll talk about some of the strategies that I think you have to employ. But, again, the easiest method, I think, to potentially increase revenue without adding any cost whatsoever. And I'm going to give you some examples of what that looks like, because I think it's important to actually follow that on with something concrete, because a lot of times people just don't have the time. It's the CEO or CFO that's doing the contract negotiations. But, there needs to be more emphasis in this area, and there needs to be more diligence. And we'll talk about what some of those points are in a second. Let's continue. Next point is many behavioral health professionals will continue to work virtually, both outreach and access issues. So the implications are pretty straightforward. You have to have a strategy. Yeah, you have to be in the game to deliver telehealth services and virtual types of services. Because again, it doesn't just end with kind of a phone call or a video chat session. There are a lot of other technologies that play into this as well. But again, you have to be in the game. You have to have a plan for it, and you have to pivot from what you're doing now. And many organizations, to their credit, and I know many of you probably in the audience today have actually made that pivot. I've seen organizations pivot in 7 days, literally, when the pandemic hit, literally being able to convert their entire organization and across the multi-state environment to a virtual platform. And that for all their outpatient services, that was really, that's kind of pivot it takes a lot of thought and innovation in moving that forward. So, again, the other part of this that comes into play where you've got many more people working virtually is what are you going to do with all that office space that you have today, especially, looking at your outpatient services, and again, what are you going to do with that space? It's an implication of having this conversion. And again, I don't think we're going to go back to, a very small number of telehealth visits on an ongoing basis after the pandemic. I think it's here to stay, and it will only increase. Out-of-state competitors. We know healthcare is local, but nobody's really thought about the idea that if you're on a telehealth platform, you don't necessarily need to be physically local to be able to deliver those services. So a lot of organizations are experiencing out-of-market competitors being able to come in, and you could do that, in many ways. I mean, you could just come in with a large marketing campaign and let people know that, you're in the virtual services business. And as a provider of behavioral health services, you can do the exact same thing, in terms of being able to use those methods and technologies and methodologies to be able to kind of get in the game and get into other geographies at a much, much lower price point than you could previously. And then payers. They have to additional alternatives for access and follow-up. So again, access, HEDIS measures, ER diversion, readmission prevention, all of those things, will have implications around this virtual model as well. So what action should you be taking? Matching consumer services platforms with the best technology or no technology. Again, understanding what it is that you're trying to do that match for, converting surplus treatment space to other service lines, that's basically hopefully more conducive to a brick and mortar location. And again, you could think about what some of those might look like. Your ability to market your organization virtually becomes paramount. And so many organizations do such a great job of using social media, using customer and consumer ratings, using, customer consumer outreach and follow-up. And, it's taken on this almost hospitality industry-like follow-up and follow-through and customer service acuity and focus. And I think that's another opportunity for you to really kind of get in the game, is really ramp up around this idea of raving fan customer service. Because again, I think it can be a very key competitive advantage, and especially in this virtual model where you're able to really kind of talk about some of that using, customer testimonials, et cetera. Developing abilities to streamline access, follow-up, especially after psychiatric hospitalization, and again, it's creating those partnerships with your local general hospitals and keeping them out of their emergency room. All of those are opportunities, again, with this virtual model or even with your brick and mortar model, but to move away from these situations where are opportunities for you to action this right away. Let's continue on. Payers are operating with less money, less budget. So the implications are, more Medicaids insuring for the unemployed, additional pressure to serve duals, due to rising disability levels. We see that. COVID-19 complex patients are sicker and they have a higher mortality rate, which we all know. State budgets are being reduced and the rates are being reduced. And we know that the tax shortfalls are kind of a key driver there. More risk-based contracts for Medicaid and Medicare. We can absolutely assume that. We had value-based payments, entering the industry in a big way pre-pandemic. I promise you, only thing that's happened as a result of COVID-19 and the pandemic is an acceleration of those trends that were already happening. You'll see that in a very, very significant way. But again, backwards integration of health plans, and payers will implement more value-based payment and risk transfer to providers, or at least they'll be trying to do that. So that's the reason why you have to get on top of your data and being more data-driven. Again, we'll talk about that in a minute. So what should you be doing? around this idea that payers, have less of a budget. Fine tune your understanding of your cost. I love asking providers this question about, do you have a good firm understanding of your unit costs or your costs? And most will say, yeah, we know exactly what it costs. And then I start asking questions like, well, do you know the difference between a Cigna patient and a Medicaid patient? Is there additional authorizations, or is there additional, requirements around certain types of patients? I mean, so all of those, play a factor in terms of understanding your cost, but you'll have to understand it at a much more granular level than you ever did before. And to the degree that you can actually talk about what that cost offset is in the physical health world, that is another story that I think payers will pay attention to. They're going to look for superstar providers that are able to actually have that gap understanding of understanding not just behavioral health, but also the implications in the physical health realm. And being able to prove that out with data will become, honestly, your best friend. Fine tuning your clinical and administrative programming, again, to serve the increase in Medicaid and risk will have to be, part and parcel of your strategic planning. We've moved at Open Minds, we were really, the old model was a 5-year strategic plan. So many organizations we engage with, we're really operating on a 5-year strategic plan. I would say probably over the last 2 years, we've seen more organizations focus around an 18-month strategic plan, simply because the fast and rate of change around all the things that we've already been talking about here on this webinar. But also, now that we're in this COVID-19 pandemic crisis, we actually have clients that we're doing 30, 45-day crisis plans with. So again, the amount of change, the amount of risk actually drives the time frame down, and organizations need to be planning for shorter time frames in terms of being able to cope with, how many days cash on hand, and being able to look at the kind of clinical programming that you're going to need to have to be able to serve a specialty population or your population in general. And maybe that's across a mass, multi-state market. But again, you have to find your niche, whether it's specialty services, ER diversion, complex consumers, or large employers. Large employers are certainly understanding the implications, certainly with the pandemic, around mental health, and being able to engage in being able to impact the workforce, if you will, are all part and parcel of a large employer, self-insured employers thinking. Let's continue. So the care at home movement, I just briefly hit on, but again, the implications are the care shifts from the residential setting to long-term care models, to more ambulatory. So we're seeing that shift occur in multiple domains. But again, you have to also realize that the implications are there's legal liability of care at home, and certainly around, the pandemic has created a whole nother layer of legal liability and physical health liabilities as well. Dealing with PPE and infection control in the home model for staff, conversion on or scale of residential for long-term facilities. What do you do to convert that to something else? But again, what are some of the actions that you should be thinking about as more and more and more care is happening in the home? Develop testing of consumers and staff to address the infection and the exposure. Have a plan in place where you're able to kind of deal with that in a meaningful way. Develop a deep understanding of the legal implications and regulatory requirements for the in-home model. If you don't have great healthcare legal advice, I strongly suggest you get some, because again, all of these models will kind of carry more risk that you'll have to take into account. Promoting your new in-home programs and products to payers. And again, as you create them and being able to take them to payers, you can be absolutely certain that payers love in-home models, especially ones that work. So if you're able to show them a model that you've incubated, that you've developed, that does move treatment into the home model, and then also what kind of outcomes are you seeing? How are they different from more of a residential model or a long-term care model? All of those will have a significant impact on your ability to get their attention, because again, it has both outcome as well as financial implications. And again, those are actions that you should be thinking about right away. Understand your granular cost, and your margins around all of your service lines. Everything that you're doing today or even consider doing, all of those things, you have to have that granular level of cost. And we hit on, just kind of an example of what some of those kind of tendencies and data points may look like. But consider, other adjunct services that could be offered in the in-home model. There's lots and lots of things that you could tag on to that model, that could be easy to implement. But again, as you look at it, you've got to be strategic in terms of the way you're thinking about it. You have to think about it different and think about it from an innovation standpoint. Not everything has to be delivered by an in-person model. A lot of it could be a combination of in-person and telehealth. So there's a lot of clinical programming, a lot of experimentation that's taking place in the industry right now, and there will be some winners and some losers. And certainly you want to be incubating innovation within your organization as a key attribute here in terms of really getting at this idea of getting paid more. Because again, that's what really, you'll see some organizations really taking advantage of this and moving forward. Okay, let's continue. So I want to give you some examples. I love examples because that enables me to convert something that I just heard in theory to something that is much more meaningful. So I'm going to use an outpatient services example. So I came up with my own assumptions here. So assumption one is an organization that delivers 60,000 outpatient visits per year. And assumption two is across all payers, and the organization averages a blended rate of $47 per visit. Kind of normal for our industry, I think. But if you look at the total annual revenue that's generated from those 60,000 visits at $47, it's roughly a little over $2.8 million. So now if you think about this, so if those organizations that have not renegotiated your rates or taken a very serious look at the tactics around rate negotiation, but if your organization is able to negotiate a modest 5% across the board rate increase, that net impact without doing anything additional, nothing additional, no additional expense, nothing else, you would be basically up $141,000, again, without doing anything, without experiencing any additional expense. It's a lot of money when you think about it, just being able to just have an individual negotiate a great rate. We'll have that kind of a yield for your organization. Some of you operate with way more visits than 60,000, and obviously with many more modalities and different types of services. So let's go on to the next one, an inpatient example. So this is psychiatric inpatient. My assumption here is that an organization has one psychiatric hospital, so we're just going to be modest here, with 60 inpatient beds. And again, across all payers, the organization's blended daily rate is $650. I know there are some of you right now with psychiatric hospitals, and you're saying, I could only wish that I had $650. And then there are others that I promise you they're on this webinar that are being paid a lot more than $650. But for our example here, we'll pick something that's fairly middle of the road across the country. So the facility, my assumption here, operates at about 80% capacity, which is, again, pretty normal, I think, for psychiatric hospitals. The total annual revenue is generated from that one hospital, again, from one service line, just the hospitalizations, a little over $11 million, okay? So if the organization is able to negotiate a 5% rate increase across the board, the net impact without doing anything additional is over $500,000. So again, two examples, two different types of services. I think it's important to note is that these are doing nothing more than negotiating rates. And some of you just literally have not done it in a number of years. And a lot of you have kind of given up on the idea of getting a rate increase. And again, the tactics of that are a whole webinar unto themselves. And certainly we'll be happy to help you with those, because again, it's something that's formulaic in a lot of ways, and having the right people in place. But again, so if we push those aside for a second, let's go on to the next one. The number one reason that I hear for not having somebody who's skilled, who understands rate negotiation and contract, is we can't afford it. It is the number one thing I hear. Again, so let's just look at this for a second. Our outpatient example, netted us with a 5% increase at $141,000. The inpatient example, it was $569,400. So that's over $500,000. I know that there are some smaller organizations on this webinar, but I also know there's some organizations on this webinar that are a lot bigger, and your experience could be even more significant by actually having somebody who is highly specialized at contract rate negotiations. And we've worked with some organizations that have made decisions to put people in place dedicated to negotiating rates. in making sure that credentials are lined up, et cetera. Those organizations have really done a fantastic job of developing deep relationships with payers, unlike any others that we've seen. So let's continue on. How about a real world example? I can't tell you the organization's name, but I can tell you this is a real honest to goodness example. So this is a recent years example as well. So this isn't something that happened in the dark ages. This is something that's fairly recent. So a multi-state behavioral health provider with inpatient, intensive outpatient, or residential substance use disorder treatment. So they're multi-state environment. The organization's revenue was around $385 million total, okay? Top line revenue. The organization had not seen any rate increases in over 5 years. And in some regions, actually, they've actually experienced a decrease in rates. So the client actually hired a vice president of payer relations, okay? And again, and honestly, with a little reluctancy around, we've got other people that are really smart that know how to do this and, it can be their side job. But they ended up making the decision, based upon the consultative recommendation, to hire this individual. Their salary and benefits were about $148,000. And over the course of just the first year, this individual was able to negotiate a blended rate increase of 17%. And I have to say, again, the person was working without necessarily the advantage of data, where you would have rich data that would prove your services are better than others. It was strictly around having those relationships with the payers, having the tenacity, having a plan for negotiation. So a blended increase at 17%. So the new revenue figure for that organization doing the exact same thing was $450,450,000. So the previous year's revenue. So you saw basically a $65.45 million swing as a result of having somebody dedicated to the idea of being dedicated to payer relations and negotiating rates. And again, by no means am I promising that everyone on this webinar will get a 17% increase, but I'm telling you that in a real world example, an organization that does provide really good care, was able to kind of see this kind of advantage. Many organizations, year in and year out, that we work with, honestly see they're seeing rate increases on an annualized basis. So it's important to note that those do exist. They are not unicorns in our industry. You can actually experience these rate increases, and by the way, you can afford it, especially if you have not seen any rate increases or even decreases in recent years. This is something you have to pay attention to. So if you're a CEO, CFO, COO, or have some responsibility of leadership in your organization, this is one. If you don't take away anything else I've said all day, getting paid more, really, this is your opportunity right here. Let's continue. The tactics. So how do you do this? So, obviously increasing referrals for, your current services, your consumer referrals and third-party referrals is key. A lot of organizations do a really lousy job of marketing, frankly. So what you have to do is actually take the idea of generating referrals really seriously. I can give you a couple examples where we've done consultative work with community mental health centers, and they really didn't have much of a marketing plan. They didn't have really very many people dedicated to it. So referral development was mainly, seeing more Medicaid, but they actually decided, and they hired an individual, and they said, we are going to target a 10% increase in commercial insurance, which obviously paid a heck of a lot better than Medicaid did in this particular state. They were actually able to move the needle 8%, which is, again, a substantial increase in revenue. So the reality is that focusing in on referral sources and being able to prove out what you're doing and having that marketing individual and marketing campaigns that are focused around referrals really is a key element. Next. So virtual marketing is key. So we know that, especially in the pandemic era, you've got to really kind of focus in on how you're going to do this virtually. Most organizations are marketing and selling virtually in this era right now. But again, you have to focus in on marketing the services that are most profitable to your organizations. You don't want, you want to get rid of the ones that obviously are your dogs, if you will, and you want to bring and shine light upon the ones that are, that also could be more profitable with volume. So I mean, you have some some services perhaps that, that do have a great margin, but your volume is very insignificant. So again, that's another one where you may want to shift some attention towards generating more referrals, more volume, and more marketing focus around the idea of how do you generate more referrals, for a particular service line. The key elements of virtual marketing here, and I have 14 steps here. I'm not going to read them all to you, but again, if you want these slides, they'll be available tomorrow, as Corey said. But you have to use consistent healthcare branding. You have to evaluate the online patient experience. When you get on online and get on your website, it can't be slow, or it can't, if your social media platform, if you're not updating it with new information, new programs, new initiatives, all of that plays a role in terms of people's experience, in terms of your opportunity to market to them virtually. Optimizing current patients and stories, to the degree that you can. Utilizing pay-per-click display ads, on Twitter, on LinkedIn, and other services really are opportunities for you. They can be highly focused, generating, again, opportunities through social media. And again, I always say it the right way. It's not just, throwing something out there. This is not your teenager's Instagram account. This is really kind of intentional, marketing around social media and having the tactics and understanding about how to do that. Ask for reviews from patients. Again, consumer reviews are playing such a critical role in terms of people's choice for healthcare services, or they're referring to Dr. Google. I mean, we know the statistics there is that a lot of people are very reliant on Google searches for healthcare advice. Looking at traditional media as well, in terms of really kind of supporting your virtual efforts, and building that referrals, into your marketing plan, checking with your current patients, making sure that from a customer service perspective that, you're hitting on all cylinders, that becomes an important part of your culture and your messaging. And again, the most important one that a lot of people leave out is tracking your results. If what you're doing, is it actually generating the kind of anticipated results? And those are really important for you to put in play as you're thinking about this. So let's continue on. So again, increase fees for current services. Again, really important that we focus in on how do you add to top line here. Next. So the key elements for increasing fees, I think, really breaks down to these 4 here. Determine, what services you focus on. So, are there areas where I mean, I love asking provider organizations if you're good at everything you do, and everyone will say, yeah. And I say, well, how do you know? And so our patients tell us. You got to actually have data to back that up. So use data to prove out what services are absolutely your best from a financial perspective, but also from a service delivery and outcome standpoint. That's the ones you want to focus in on. Eliminate those services that are losing money and below market rates. Just get rid of them. A lot of them say, well, they may generate this, or there may be a need, and they may be a feeder to this other service. Don't take that temptation. Conduct a thorough cost analysis. Competitive intelligence, understand what your competitors are being paid. Obviously important. And if you're being underpaid and you can't get the payer to change your rate in that rate expectation, then cancel the contract. I've seen organizations do that, and it may take a little time for it to come back around, but the yield of result is very, very significant potentially. Let's continue. So the change in reimbursement models for current services. So the ones that you're already delivering. All right. Next. All right. Key elements are really to consider those services that your organization really is kind of uniquely equipped, something that you've already developed kind of a local following for. Those are really important, that you really understand, if your margins are good in those services, and understand where the opportunities may be for increased reimbursement models. Fee for service with bonus payments, maybe looking at case rates, or various risk contractings based upon kind of specialty services, or even full risk contracting eventually will be part and parcel of everyone's plan. But you have to know your cost. You have to know, that you can deliver the outcomes that payers are looking for. You must know those outcomes that really align with what the payers are looking for and will get their attention. And again, the data system to inform those kind of points that you're trying to make. And of course, the relentless pursuit of improved payer contract negotiations. And I think, we've already made that point pretty strong, just a few minutes ago. Let's continue. propose new services, brand new services that aren't in play. And that it really kind of, let's continue. It breaks into a couple of different categories here. One is, expanding the volume of existing services, expanding your geography of your existing services, and expanding into complementary services, things that will go well and be blended with your organization's potential capabilities. Let's continue. So we're going to focus in on the expand into complementary services. That's where I think the real opportunity is, and where the opportunity going forward is, especially in an integrated service model. Let's continue. So let's talk about service line adjacencies really briefly. I defined it here because, again, it's a term I think that's widely used here, but service line adjacency are new business areas that most often build from an organization's assets or things that you're good at, or an existing services that complement your brand image, or the things that people know what you do. If you're an IDD provider, people know that. What are the services that complement that? Or if you're a behavioral health provider, where are some of the opportunities there? And some of them may not be obvious, and we'll talk about that in a second. So let's continue. How do you do that? That's the next one. And again, I have a process that you go through, I think, in terms of looking at what service line adjacencies. So you generate a long list of adjacencies, and you set some criteria around and get it down to a short list, and then investigate 2 to 3 of the most promising of those service line adjacency potentials. And then again, go enter into a pilot program, try to minimize your risk as, in any way, that shape or form that you can, so that you're able to move into this adjacency with low risk, but you're moving forward, you're expanding your capabilities, you're expanding other healthcare providers' reliance on your organization. All of these are really key in terms of really developing those service line adjacencies that at the lowest risk profile that you can create. Let's continue. So again, a couple examples here, just to be concrete about it. So if you're a mental health provider, developing a primary care line that's specifically for severe mental illness. I mean, the patients themselves are hard to deal with, perhaps, and you could probably even do the same with IDD, primary care for high acuity IDD. Again, tough patients, and again, even your competitors potentially could become customers if you have these services in place, because you're providing a service that is in high demand, that's highly specialized, and it's one that you could actually get paid fairly well for, because again, it's going to require a heavier lift, and it's one obviously you want to make sure that you have a payer's buy-in before you get into it, so that you can negotiate that rate up front. But lots of opportunities for service line adjacencies if you kind of break it down and you want to jump into it. Let's continue. So what are the to-dos? Let's get down to the concrete brass tacks here. And again, moving from data informed, which I promise you virtually everyone on this call or this webinar is data informed. You've got plenty of data, but you have to become data driven. And again, this is a webinar into itself, is how do you become data driven? Let's go to the next one. We actually at Open Minds have a model for how do you become a data-driven organization. It really encompasses 12 key steps for how do you convert from data-informed to a data-driven organization. And again, a lot of people have this mindset that we've got data, we've got more data than we can use, but it's the important data that becomes key elements that are really going to drive your decision making. And that is what being data-driven is about. Next, what you want to focus in on is these top or the bottom 3 areas here, number 10, 11, and 12, performance-based elements, adding those to your compensation, and shared select performance with data for external stakeholders. And then again, sharing real-time performance data, with partners and even internal staff. All of these are really important in terms of becoming much more data-driven and being able to make data-driven decisions. And those are the kind of decisions that will yield the kind of financial performance I think most organizations look for, and actually will drive outcomes, the kind of positive outcomes that payers are looking for, that you're looking for to deliver to your patients. Continue. Cash is king, and again, I'm not going to dwell on this one. This is a whole webinar into itself. Again, I've said this, and some of you probably have heard me say this. Obviously your brand does matter, but Priceline for healthcare is coming. And those of you have seen the Priceline app, so you're able to get the discounted rate, where people are bidding on your service, your hotel stay or whatever. But more people are shopping for healthcare online. You have to take this seriously, and you have to have price transparency in place. You have to have people that are dedicated to the issue. You have to look at maintain a database of what those, fee for service cash payments look like, what kind of cash discounts, make sure you're consistent with that. And then again, be very creative with payment options. Maybe you have, some kind of, payment option program that you could offer to your patients, your consumers. So all of those are really key. But again, as we move more towards this hospitality kind of model in the future, I think it will become very important. Let's continue. So again, executives have these questions and that you should know. Again, they should be part of your mind. I'm not going to dwell on these. I want you to take these into consideration when you're thinking about all that we've gone through today. So when you get the slide deck tomorrow, make sure that you're going through these and making sure that you have this, check marks by these, because these are the ones that I promise you're going to want to make sure that you have in place to be competitive going forward, and having your organization positioned not only to deal with COVID, but also the post-pandemic era, which I think will be an exciting opportunity for many, and it will be failure for others. So again, pay close attention to these kind of questions that should be part of your thinking right now. So next. So the big question is, what must you do to remain an independent specialty provider organization? I think it breaks down to, what services would make consumers pay out of pocket and not go to their health plan for reimbursement? What services do you have, and how do you highlight those? What service would make a health plan manager contract on a single case agreement to go out of network? In other words, what would really get a payer's attention in a big, big way? And again, there's some suggestions here, the things that you must do for that to happen. These are important. And again, I think there's 5 key elements to that. Make sure that you're dealing with the numbers, your value equation is there, that it's obvious. You have raving fan customer service, your ability to engage people in their health and wellness and their families and their constituents, and then a marketing budget, for the acquisition of customers. All of these play a role in terms of really getting these 2 questions answered. Let's continue. So how about summarizing all that I've kind of thrown at you today? And I know it's a ton, but let's kind of go through it. These are the big learnings right here. So number 1, if you're a cat, learn to like dogs. It's real simple. So again, if you are a payer, learn to like providers. If you're a provider, learn to like payers. So let's go to the second one. Guess what? If you're a dog, learn to like cats. So again, the idea is that we have to learn how to partner. And again, this is not something that is intuitive to most behavioral health or IDD organizations. Learning how to partner is something that's brand new, and learning how to partner with a payer is even more scary because of a lack of trust that's gone on for so many decades. But again, these are types of things that you have to learn in action right away. Next. Silos are for storing grain, not for delivering services. Again, behavioral health and IDD services and other services in our industry, health and human services, have literally operated in a silo for decades. And this is an era where everything is about to become much more integrated and bundled. You've got to start figuring out how to get out of your silo and start to operate in an integrated manner, and realize that that is the new era that you will be operating in, whether you're already doing that to some degree, or I promise you within the next 5 years, you will see a substantial increase in this. But you've got to get out of that silo. Let grain be stored in there, but your services shouldn't be delivered in a silo. Next. So next one, if you build it, they will not come. Again, I think consumers are going to be seeking these at-home services. Again, these are moving away from this. We have to have a physical location. Mindset is one that you've got to convert, and you've got to get away from, and realize where it is that's appropriate for your consumers to seek treatment, because they do want it in their home. It helps with stigma. It helps actually in some treatment settings. I mean, we've seen addictions treatment providers actually do a phenomenal job in an in-home model. So these services are being incubated and actually proven out, and the outcomes are there as well. So get in the game, start to innovate in this area. Next. If you don't ask for increased rates, I promise you that your rates will remain exactly the same as they always have been. So you have to start taking action and being purposeful about looking at rate increases, and understanding that you've got to be very diligent, data purposed, and very, very focused in terms of developing those relationships with the key payers that you have to deal with. This is an area where I promise you most organizations of any size really need to have dedicated staff that are focused in on this. And again, this is a webinar by itself where we could, if you don't know how to do this, we'd Open Minds would be happy to help you set up a platform for how do you set this in motion, because again, there's so much opportunity relative to getting into the right regard with payers and getting into the right contracting models. Next. Start thinking about IT investments. It's having a secret competitive weapon, if you will. And again, most CEOs, CFOs, and COOs, they look at IT as a big waste of money. But if you start to think about IT and you think about some of the capabilities that you could do and some market advantages that it could yield, some treatment advantages it could yield, it really could become your secret weapon. It could be one that nobody in your competition realm could even really compete with you on. And if you get far enough ahead with the secret weapon, if you will, whatever that service delivery mechanism looks like, virtually or otherwise, it really will allow you to have the ability to operate at a much higher level and being able to drive those kind of relationships for increased services and rates with payers and others. Next. So we did get some questions from our Circle members. I would be happy, and we're up on the top of the hour, and I appreciate everyone hanging in with me. I'm try to dump as much information as I possibly could. If there are any questions, if you could go ahead and type it into the chat window, I'll be happy to address any of those. We are running out of time here, and I'll be happy to take any if there were any. Otherwise, we'll try to actually maybe try to answer some of these maybe through social media, maybe on our LinkedIn page or whatnot, and try to give you some more tips as you maybe think about some of the things that you learned today. But Corey, do we have anything out there?
Yes, Paul, thanks again for the presentation today. I want to thank everybody for attending. We do have a question from Joe. He writes, can you elaborate more on the payer budget reduction implication? Through the first 6 months of 2020, almost every publicly traded insurance company is reporting a record earnings and shrinking medical loss ratio. Okay,
so you have to realize something very important is that there's a difference between budget and earnings. So the reality is that while you're right, these organizations have provided record earnings, and it's because people aren't seeking services. I mean, basically they are generating revenue based upon not having to pay anything out. I mean, you could say, the COVID patients, but that doesn't really amount to being a lot of people staying home, staying out of healthcare settings, not really seeking any type of either optional or marginally optional healthcare services. That's the reason why you see these commercial payers with a tremendous windfall. But again, their budgets are constricted as a result as well. In other words, the kind of revenue that they've been sitting on, is not going to last. A lot of organizations are retooling. Some organizations are going away. I mean, how many corporate bankruptcies have we seen in recent weeks? So all of those will have a top line impact on commercial payers that you have to pay attention to. The amount of money available for health insurance is going to reduce, at least for the short term in the coming months and potentially year, as we head through a very challenging financial time. But again, don't be fooled by the record earnings, because again, that's a catch-up quarter, if you will. But we're talking about revenue, not profitability here.
Hey, Paul, this is Meena. Thanks for the presentation. I have a question that came in from a member, from Wendy. You have been encouraging innovation and thinking about complementary service lines, expanding service lines. At what point in this process should I begin conversations with payers as a provider executive? Do I talk to them when it's still an idea? Do I have to wait for it to be fully fleshed out? Do I have to pilot and go to them with results? What's the deal there?
Well, to me, the opening conversation, number one, is you have to know who to talk to at the payer, which is sometimes the challenge into itself, and the reason why having a payer executive kind of in your camp and on your staff. But secondly, I think it's important to realize that you want to have these conversations about what their specific pain points are that you can solve. So, and again, payers are very open with what their needs are. I mean, they have gaps in their networks. They have specific high cost things that you couldn't even, maybe it's a lab cost. I mean, but they have specific costs that they're trying to address tactically with programs. And again, to the degree that you can understand that and potentially then build service line adjacencies around it if it makes sense for your organization, that's the way to start. So you don't have to have, and in some cases it is better to have a fully fleshed out plan that you can actually go in, that's really well thought out and say, but you have to be fairly certain that that is something like an ER diversion program or a readmission reduction program where you already know that there's pain point there. Your general hospital has, a readmission rate that's 10 points higher than any other in your state or country. So, the reality is that you've got lots of data points that you could focus in on and actually action with a payer is in a fully fleshed out manner. But starting those conversations, knowing who to talk to is kind of the place to start.
Great, thanks, Paul.
Well, listen, thank you all very much for attending today. I can't tell you what a thrill it is to be able to do these, and we have obviously a lot to share in the coming weeks. I certainly appreciate your attention this afternoon and look forward. I'll be, I think, actually speaking in the coming weeks, so look forward to that as well. Thank you.